Okay, all right. So what we've covered so far is starting out, when we're discussing mobilizations with movement, we've covered some basic principles, but there are three different types of joints that we want to group together as we're applying mobilizations with movement. The first group would be the hinge joints that we covered in the finger.
Yep.
The second group is going to be the adjacent long bones, such as the metacarpals. And you know, of course, that'll apply to the radius and ulna and in the lower extremity, the comparative groups. But the third area I'd like you to speak to a little bit more, because that includes carpal bones, but it's not the specific rules that apply to the other two groups.
Carpal bones are a little bit different. Carpal bones, tarsal bones, the facet joints in the spine, these are very important, the sacroiliac joints. With these structures, you can't get, for instance, a facet joint and move immediately or laterally or rotate it. That just doesn't apply. With these joints, you normally just reposition one surface on the other. Normally it's a ventral or a dorsal direction. There's no hard and fast rule.
Sure.
But you haven't got the same options.
Right.
It's just a case of repositioning painlessly.
Yes.
Immediately get an increase in function or movement or whatever you're after, and it's got to be long-lasting. And they can be so rewarding and exciting. Right. Things like the misplaced scaphoid in the wrist. But that'll come up with all the techniques.
Sure. So as we have compartmentalized our thinking, as we approach mobilizations with movement in the body, we're covering hinge joints, freely mobile joints. The
you're allowed one indiscretion.
Yeah, that's all right. The adjacent long bones.
Yeah.
And now the carpals. Those are the three type of groups that we have, and all of the principles of mobilization with movement applies, because we search for the pain-free direction to mobilize. We apply overpressure once we get a full range movement, and then we perform sufficient repetitions.
And if you think about it, they now can treat any part of the body without even teaching them. We've given them the sort
there you go.
Let's go home. Go.
Yep.
Okay. We've discussed the fingers, and just in winding up the fingers are hinge joints, and the techniques we use on fingers are used on other hinge joints in the body. I'm talking about the elbow. You might do a medial glide or a lateral glide or a rotation. The same with the knee. Come down to the feet, the toes. You apply the same rules and regulations, if you like, because they're hinge joints.
So if you would just demonstrate mobilizations with movement for the proximal interphalangeal joint in the index finger.
My pleasure. Right, here's the proximal joint. And you're going to fixate with one hand and reposition with the other. You know exactly where the treatment plane is. You know how those bones lie beneath the skin. And let's assume it's been traumatized and it's grossly swollen. You handle it with some sensitivity. You must be careful. If you just squeeze, that's going to hurt the patient.
It will hurt.
Now, even setting yourself up, there are things to... Well, you've got a bit of sponge there, and good, you remember to bring it. If you've got a very painful joint, I know you can't see on the camera what's happening, but it can be done through foam plastic, and it's much, much more comfortable. So we'll put that aside.
Okay.
But you locate. So the first thing you do is to select the two facets of the joint, proximal and distal, with your thumb and index finger. And when you're positioning on the target, so to speak, your fingers are together. There's
so
no
in essence,
space.
your proximal hand is on the middle phalanx, on the distal end of the middle phalanx, and your distal hand is on the proximal end of the middle phalanx.
I reposition in the pain-free direction. If coming up's painful and going down is not, that's going to be the sustained direction of correction. Now, if there's a little bit of pain one way and a lot the other, again, go in the direction of a little bit of pain and just alter very slightly the translation angle. And suddenly the patient will say to you, hey, that doesn't hurt. Because before you even start, you say to the patient, you let me know if there's any pain at all. Now, having corrected the joint surfaces, I'm going to ask Julie to slowly move her finger into flexion. If she moves it quickly, I will not be able to stay on target. Now, when you're treating a real patient, what makes it long-lasting is the overpressure.
Right.
And if you don't apply overpressure, sure, it'll move, but you won't get the optimal result. Yeah. And if you don't get the optimal result at the time of treating the patient, then it won't be as long-lasting. Sometimes it is. Yeah. But I'm talking as a generalisation, reposition gently, sustain, go with it. Now, I will ask Jules to push her finger further. Can you come up underneath so that... And she's pushing on that involved phalanx.
On the middle phalanx, actually.
Yes, she is. And then up, and look how I remain on target and reposition.
Very good.
All the way. And back you come.
Okay, so on and off. Do you sustain that pressure for any length of time?
Oh, I didn't mention that before. Yes, I would hold it for a couple of seconds. Huh. Just to, ooh, and let go. Right. And if it's an acute finger, I'd perhaps do it 4 or 5 times. I've got a result. Let's not be silly.
Sure.
Let's not cause any exacerbation. You've got a result. The patient's happy. I'm happy.
Could you do that again for me?
Yes.
Because I was noticing that you're moving your hand as the bone moves.
Yes.
This
my
distal
whole hand comes round.
This one is kind of staying still.
That's right. Mustn't move.
Yeah.
Yes.
Back and forth. Okay.
Thank you.
Overpressure.
Yes.
Right. If you could you show me a rotation if rotation is necessary in there?
Well, yes. Good on you.
Do you change your grip? Or?
Yes. Now, with a rotation, you fixate proximally. That's fine. Mm-hmm. I don't care if you grab down the shaft of the bone. All you're doing is just rotating it. Mm-hmm. And you'll find you go one way, ouch, the other way, oh, that feels all right. So you sustain it, and again, they slowly move the finger. They give the overpressure. You keep that rotation on till you come back to the starting position.
And then you perform repetitions.
You form repetition. With an acute finger, if you've got a good result after 3 or 4 goes, don't go anymore.
All right.
That joint's sensitive, it's been hurt, and you won't get any sort of soft tissue reaction. Sometimes, now that you've mentioned rotation, thank you very much, you may find that you've gone one way, it's painful, you go the other way, it's less painful, and you try to get rid of that pain, and you just can't. If you add a little rotation and then do your lateral translation, the pain's gone.
Oh, so you're now combining a glide with a rotation.
That's right. Yeah. And Jules is remembering to give the overpressure.
Well done.
Thank you. You're a good patient.